You focused a lot of your clinical work on home tonometry. What's the biggest way you think home IOP monitoring is going to change how we manage glaucoma patients over the next several years? And what is still holding it back from broader adoption?
Those are really, really great questions. I think one of the biggest insights that we came up with in terms of when COVID hit was how do we monitor our patients' pressures, right? What resources are there? For a lot of other diseases like diabetes, there's home monitoring. There's quite a lot of literature, a lot of data showcasing that patients can monitor these issues themselves, right? So I think home tonometry brings in a nice lens in the sense that it allows our patients to have access to it. At the same time, some of the limitations that prevent patients from being able to do that is the coverage, right? So there are certain codes that are to be used. There is the actual, do you purchase one? Do you rent one? If you want to rent one, how does that work? And there have been different discussions of which modality may work the best for patients. But I definitely think coverage and whether it would be covered by insurance or does it have to, would it be a self-pay issue, drives a lot of care in general in terms of reimbursements, not so much from physicians, but so much for our patients and whether that's going to be covered on top of everything else that they have to pay for their health care.
At WIO, you're speaking on the importance of ergonomics for career longevity in ophthalmology. What's one ergonomic habit or practice change you'd tell an early career glaucoma surgeon to adopt right now?
I think the most important thing for all ophthalmologists is that you have to know how or what you look like when you're operating. So the number one tip is actually having someone video you or take a picture of what you look like on the side, because that may give a lot of clues as to what needs to be adapted or changed. And certainly for younger ophthalmologists, I want you to picture your form or picture your habits because those things become ingrained. And it's much harder to change those habits when you've developed bad habits rather than starting out with something that may not feel comfortable, but is actually better in the long run.
As well as being director for your department, you've looked closely at drivers of burnout across the health system. Is there something specific about glaucoma as a subspecialty, the chronic disease management, the volume of patients, the surgical demands that makes burnout risk look different for glaucoma specialists compared with other areas of ophthalmology?
I think that's such an interesting question. I think that as all ophthalmologists, we kind of go into the field, kind of working with patients over the entire course of their lives in terms of their sight, and so precious. I think I certainly think that all ophthalmologists, actually all physicians, have some degree of burnout due to the system-wide issues. I've been very fortunate to have the support in my department to be the well-being director to look at some of that. I think specifically for glaucoma, I think the uncertainty of the disease. And so sharing that news, sharing that uncertainty with your patients, getting their input and getting their perspective of, the reasons why we need to further lower the intraocular pressure is very important because it doesn't necessarily translate to better vision. It's not as though with cataract surgery, we can say, okay, after your cataract surgery, your vision is going to be much improved, right? With glaucoma surgery, when we maintain or when we obtain a certain eye pressure, it doesn't necessarily translate over to immediate good vision, right? What we're doing with maintaining the pressure is maintaining the vision and specifically more maintaining the peripheral vision. And I think for anybody, it's a little bit harder to understand. And I think having that conversation can also be harder for those of us that have it day in and day out.